So welcome everybody, and I know other people will be trickling in because we're starting like 12:32. I am Susana Morales, and I'm excited to have you attend our Health Equity Seminar Series, Cornell Center for Health Equity, with our COVID-19 Health Equity Initiative awardee presentations. So we're very excited to share our work so far. These are works in progress, but we have wonderful awardees, and 5 of our 6 are going to be presenting today. Just for those of you that are new to our group, because we did invite some special guests, including some of our pre-medical students and others that are interested in medicine. So we'll have a really interesting, varied group of physicians and future physicians and others attending today. The Diversity Center of Excellence is the education core of our Cornell Center for Health Equity, which is a bi-campus Weill Cornell Medicine and upstate Cornell University entity. And the DCOE supports diversity in the healthcare workforce with educational programs for medicine pipeline, house staff, residents, fellows, and faculty. Our Health Equity Research Fellow will be one of the people presenting today, and we're very proud of his work. But after our initial DCOE grant, we also received funding from HRSA from the CARES Act to fund COVID-related work. And of course, many of us had already been engaged in COVID-related work, but this prompted actually new initiatives. We decided to design that work into supporting projects within our institution. And we decided to fund 3 types of projects: a health equity telehealth COVID-19 innovation project, which would support e-learning and telehealth initiatives; a health equity COVID-19 faculty student research collaborative, which would support research on COVID-19 health disparities and involve our medical students; and a health equity COVID-19 academic community partnership, which would fund projects with community partners engaged in testing, community education, outreach, and also promote work with our students. So we're very happy to introduce you to 5 of our 6 awardees and have them present on their projects, on the work so far. And I'm going to hand it over to Dr. Martin Shapiro, who's one of our COVID grant and Center for Health Equity key faculty, to present the first 2 speakers. And I just want to tell Martin how much I appreciate you and all of your collaboration.
Thank you. And it should be said that Susana Morales, who is the principal investigator on the Diversity Center of Excellence grant from HRSA, which led to the supplement, has been a passionate, dynamic, and very effective leader of that effort. And she's not going to let anyone stand in the way of transforming the institution into one that's more equitable and just and diverse. The speakers will each have about 5 minutes, and then there'll be time for questions. And we'll try to really stick to that format. So think of what you'd like to ask them about their projects. And a lot of them are just underway. But our first speaker is Peggy Leung, who is an assistant professor of medicine in the Division of General Internal Medicine here at Weill Cornell. And her topic is identifying and outreaching to high-risk ambulatory patients during the COVID-19 pandemic.
Thank you. Let me share my screen. Alrighty. So good afternoon, everyone. And thank you so much for the opportunity to share our outreach efforts during the COVID-19 pandemic at our Weill Cornell Internal Medicine Associates, or CIMA practice. As many may already know, our clinic is a shared resident and attending primary care practice where the attendings and residents have practiced together for decades and are open to all the same insurances. So with a near equal split between Medicaid, Medicare, and commercial insurance, our multicultural, multilingual patients really come from all 5 boroughs and routinely travels via Access-to-Ride or the MTA to get to us. And like for many practices, COVID-19 really has changed the way that we provided care. So really, how did this project start? We actually have to go all the way back to April 2020 as we were all locking down. It was really unclear then how inundated our ambulatory practice would be at the height of the COVID cases in New York City. And unexpectedly, initially, we were met with calm, like an eerie calm, sort of welcomed at first. But then when the calm persisted, we were wondering, where are our heart failure patients? Where are our diabetic patients? And many of us PCPs pictured here just started calling patients that we were concerned about to check in. And that's really when we uncovered the deaths, the PTSD, the fear about just returning to care. And the fear even extended to calling our practice, because they would think that this would then naturally mean they would have to come into our practice and visit our practice, and going outside really was a death sentence, or felt like a death sentence to many. Or they just thought we were closed. And so as a practice, we really had to confront, like, are we caring for our patients to the best of our capabilities, especially those with vulnerable needs? We could really no longer rely on the traditional models of wait for the patients to call and reach out. And the pause, if you guys remember that term, gave us time to really re-envision what truly defines us as a practice and as providers. So we built a team to address this particular issue. And you can see on the bottom row of the photos are our 3 newest members, Andrea, Diksha, and Diana, who are our medical students, really made possible by this grant, who also similarly valued this outreach. So our objectives were threefold. One was to determine the prevalence of medical needs and structural vulnerabilities among our high-risk established SEMA patients during COVID-19 through a telephone-based survey or interview. The second was to understand our patient attitudes towards accessing in-person and virtual care at SEMA, again, during this time frame. And the third was to train medical students on their ambulatory medicine clerkships to identify and address in real time these medical and structural vulnerabilities, that is, to match the patients with appropriate healthcare services so that we can mitigate those needs. Really, to accomplish this, we had a couple of different steps. So first, we had to decide what high risk meant for us as a practice. So we were able to use a couple of validated tools, so a validated EPIC risk for hospitalization easy visit tool that was, again, made available by our EMR, along with provider-driven identification. Of course, because our available EPIC risk tools really didn't take into account social terms of health or other social risks like food insecurity and housing insecurity. Really concurrently, we also had to develop our telephone-based survey to fit the needs of our practice. So the Anderson and a Day model of health services utilization was really our guiding framework in our survey creation. This model really posits that predisposing factors like socio-demographic characteristics, enabling factors like health insurance, poverty, access to transportation, perceived needs like their symptoms, evaluated needs like their specific health conditions, really all combine to influence how people utilize healthcare. And with that understanding and with that framework, we created a 45-question survey with 3 main sections. The first section asks about healthcare related access and outcomes during COVID. So what happened to our high risk patients? The next session asks about their current healthcare related needs. And then the last asks about the preferences and attitudes towards future healthcare delivery. Like, how do you wish to receive care moving forward? And then the third part, so this outreach or this telephone icon you see, we had to train our medical students not only on how to make those outreach calls, but how to address barriers as they were identified. Like, how do you find appropriate community-based organizations to best address food and housing insecurity really near where the patient may be residing? So we had to create workflows that encourage communication of our survey results with all members of the healthcare team. So all the survey results were emailed to the PCP. A telephone encounter was placed in the patient's chart to highlight the barriers, either with medications or social risks. And then messages were routed to social workers when mental health related concerns came up, and also to practice administrators who assisted in expediting access or appointments to the clinic. And lastly, as our outreach calls were made and barriers were identified, we had to analyze if there were recurrent barriers that required the creation of new workflows to even better address the needs of our patients within our practice. So as for progress thus far, in a little over 6 months, we're able to fully complete 209 patient surveys over the phone. We had about 29 people decline to take our survey, and we were unfortunately unable to connect with another 30 patients. Of the 209, a majority were over 60 years old. About 65% were female. We have a near equal split amongst our ethnicities and races, and the majority of the patients who responded had Medicare. And we are still in the process of collecting all our outcome measures. So as for next steps, there are still some ongoing discussions about how to best analyze our data and how to best use our data to better advocate for our patients. Some potential directions include using a qualitative approach to identify and examine our high-risk patients for their top health-related concerns during COVID-19. Additionally, we can next examine how our patients wish to have their care delivered in the future, trying to answer, the question of what are their attitudes and preferences between virtual and in-person visits. And there are plenty of potential questions we can ask our data set and advocacy of our patients. I just want to thank you again, everyone, for your time. And I would love to hear any ideas, tools, questions you might have that can help better support our patients.
So we do have some time for questions, but I have one. Of the patient, I don't know if you've, in what detail you've analyzed the data yet, but what proportion of the patients really needed an intervention? Like, for what proportion do you think the call was useful?
I would say all needed an intervention, depending on which, of course, some just needed another appointment, if that's a simple intervention. Some needed referrals to, their physical therapy when it was still happening at that time, or just medication barriers. So yeah, I would say almost pretty much all needed needed something that we could help with.
Anyone who has a question, just speak up. Well,
I have a question. Thanks, Peggy, for all your wonderful work always. I wondered if your questioners uncovered current cases of COVID in the patients or their families when you were calling.
Yeah, not to as high of a frequency as I think we would expect given the numbers that we saw in New York City. A lot of our patients are high-risk patients. I think we're doing a pretty good job at following the quote-unquote rules about staying at home and social distancing because of their existing risks. There were a few hospitalizations, and I think deaths had come up. Deaths I think only 2 were related to COVID. Others had passed away, and we were updating our records. But not as much as we thought. But there were a few resources where we could recommend people to, the Test and Trace Corps that's been doing amazing work in the city. So I think one of the really great things that we could do is really address problems in real time. If we found the barriers, we could address those barriers and connect people to resources. And the PCPs were definitely involved, and we could bring them in a little bit sooner. But so much of the work really was done by the medical students to get people to the right places and re-plug them back in and just tell them that we are here.
Any other questions?
A quick question. Besides the medical students who were the ones who actually helped do the work of referring patients to what they need, did you have office staff also help, or was it solely medical students who were doing the work?
Yeah, making the calls, the care managers for I think a good month in July were also a big part of this process. I think, but all the telephone interviews were done by the medical students.
Okay.
And care managers.
Do you anticipate continuing this program of calling people, or is it over now?
Yeah, we're still making calls at this point. We're regrouping it or coming together as a group to figure out, do we need additional calls? Because we're finding, really important information. And we're hopefully integrating some of this into the ambulatory clerkship, because they do learn a ton about what resources are in New York City. They do, get some, they are interviewing. It is direct patient care. So there is definitely some educational value as well. Whether it is to sort of the same degree in, a year, or with the same volume of calls, probably will reduce a little bit as we, people get vaccinated, and maybe we'll redirect our efforts elsewhere.
A quick question, Peggy.
Yes.
Would you be open to sharing your your resources and your survey with another department. I mean, the Department of Neurology, and we could certainly use this kind of work.
Sure, not at all. Feel free to email me. I'm more than willing to share the survey.
Thank you very
There's a
much.
question in the chat from Carolyn Chu, one of our pre-medical students. Hi, Carolyn. She's having trouble with her mic. She's curious if and how you're saving and tracking the community-based organization information for future use.
In terms of, we have one of the websites that we use that I absolutely love is the Height site. It's organized by the Greater New York Hospital Association, so it's frequently updated. And you can group resources by zip code, and so it's not like we just have a big list of ongoing references that we don't have as much, that it doesn't get updated as quickly. But the Height site I absolutely recommend. It's great to use for really all my primary care patients.
We're going to have to stop this interesting discussion. We look forward to seeing these results written up, and it looks like they can have an impact elsewhere as well.
Thank you, everyone, for your time.
Okay. Let's go on to the second presentation. And this one is by Gwendolyn Jack, who's an assistant professor of clinical medicine in the Division of Endocrinology at Weill Cornell. And her topic is telereach, leveraging teleservices to recognize, empower, and advocate for community health, that is REACH partnership. Gwen?
Hi. Hi, everyone. Thank you so much for the opportunity to present my project today. So like was mentioned by Dr. Shapiro, my project is telereach. All right, so this was really born out of this challenge that we've been encountering, right, during COVID-19 pandemic. How do we reach out to the community and have that hands-on approach when we have these COVID-19 limitations? And so this also presents an opportunity to really extend our reach to the community in innovative and transformative ways. So we start to really address some of these limitations by bridging the gap using video conferencing and providing interactive virtual seminars on different health topics that were selected by the community members. And this incorporated identifying potential barriers and then also providing them with the necessary technological tools so that they can actually engage with the virtual seminars. So this involved really enhancing that student, faculty, community, institutional partnership. So our community partners were Timothy Baptist Church and Ellen Restoration Church, both of which are in Brooklyn, New York. We also enlisted Weill Cornell medicine faculty to present on the different health topics. And as you all know, wonderful Weill Cornell medicine students who would collaborate with the faculty to help co-present some of these topics. So the first phase involved a needs assessment, which I'll talk about in a bit, and then also the recruitment and publicity phase afterwards, and then actually implementing these health seminars, and then lastly reflecting and having a graduation ceremony. So the needs assessment was twofold. It involved a health topics needs assessment as well as a technological tools needs assessment. So for example, for the health topics, we asked them questions regarding what topics they wanted to really hear about. And COVID-19 vaccine was quite popular, followed by breast cancer and prostate cancer, as well as prediabetes and diabetes. And then regarding what tools they actually needed to be able to engage with the material, that involved tablets, projectors, and laptops. So those were purchased by us. So we recruited Weill Cornell faculty and students right afterwards. We purchased and distributed the tools to the churches, and then they were able to publicize it through their respective means, whether it was social media, through flyers, as well as phone calls to their congregants. And then our wonderful Weill Cornell faculty and medical students were able to lead the sessions. This was really a discussion with the community members. And we included a pre and post knowledge assessment for all the participants as well. So this was really targeted to that topic that was presented at that particular time. So this was our flyer for the different presentations for Black History Month. So we had Dr. Susanna Morales and Dr. Holcomb presenting on COVID vaccine. Dr. Tagawa and Dr. B presenting on prostate cancer and breast cancer, and I presented alongside with Rachel Stahl on prediabetes and diabetes. And afterwards, the phase that we're in right now, again, incorporating this into medical education, wanting the medical students to be able to reflect on their experience, engaging with the community, also having a focus group for the participants from both churches on what worked well and what did not. And then we're going to cap it off with a virtual telehealth graduation ceremony on Thursday, April 29th. This is within Diversity Week, so we're very excited about that. And this is, again, to just acknowledge the contributions from the students, the presenters, our partners, and then also our participants who were very, very engaged. Dr. Morales will tell you that the sessions were supposed to run till 8:30, and they actually ran beyond 9 p.m. and all the participants were still engaged. So there were some challenges that we encountered, just to highlight a few. Initially, we had actually planned on having monthly virtual seminars. However, there was a delay in terms of obtaining the needs assessment data. But through that challenge, again, we see opportunities. So actually, we were able to transform that into a weekly series that coincided with Black History Month. And I think this actually helps because it was we were able to maintain consistency for the members. So I think it actually improved our attendance. And then another challenge was just the different needs of the two faith-based organizations that we had. One started off with knowing how to use Zoom, and the other congregation was not as familiar. So really being able to adapt and tailor our approach accordingly. And then our pre and post knowledge assessment, Rocio can attest to the fact that we've worked hard on creating these assessments. However, it was really challenging corresponding those who registered for the event versus those who were actually part of the event, and how do we actually see the before and the after. And then also the challenges of Zoom. So some were actually calling in versus others participating via video. But again, we see opportunities through that. And I think moving towards a focus group, this will allow us to see the pre and post assessment in a different way. So just a huge thank you for all those who are involved. Wanted to really spotlight, of course, Dr. Morales, but Dr. Rocio, who has been really the engine behind this, our wonderful medical students, Hector, and Jimson as well. Daisy has been instrumental in this as well. And I also wanted to thank our co-recipients for the COVID-19 grant, because we've been having the meetings and through their feedback, I think optimizing this project.
Great. So we do have time for a few questions. How generalizable do you think this kind of a program is?
Yeah, so I think it's pretty generalizable. I think, one of the things that it really involves is having that needs assessment, right? And one of the things that we learned is that we can't use the same approach for both congregations. So I think in moving forward, one of the things that I want to do is making sure that the tools that we have are applicable to the people who we're actually presenting to. So making sure this is actually being driven by the community that we're serving.
So given the 187 languages that are spoken in Queens, how much variation do you think you need to do?
Well, we can always have interpreters involved as well, and then also making sure that some of our material that we have is translated.
Sure. There's some
Dr. Jack, quick question. Terrific talk, terrific project. Did you record these sessions, and are you considering, even without a formal needs assessment, assuming that there are communities out there, other faith-based organizations that would be interested in prostate cancer and breast cancer and COVID vaccines, at least giving them to people for an alternate way, to a link to watch those presentations, even without the interactions of questions and answers?
Yeah, so great point. So we realized that midway through, so the last presentation was actually recorded, but that's something to consider in the future.
Maybe you can ask the people who presented to come back and record something.
Yes.
Absolutely. Our presentation, of course, we're resuming a version of it on Tuesday, pre-advertisement for COVID vaccine ambassadors. So it's not.
That's why I slipped that in there, Susanna.
Yes, of course, not completely dissimilar to what we presented to the community, but updated with the new vaccine. Martin, I think we're over time, but there was one question in the chat. So I do want to say
We
that
have
one. How did the
24
church
seconds.
participants have the ability to connect with Zoom technology and internet?
Yeah, so great question. So one of the questions that we asked them in the needs assessment, the technology needs assessment, was if they were having any issues with video conferencing in the past, who did they actually reach out to? Or were they actually ever having any experiences or negative experiences with video conferencing? So for people who had those challenges, they would have expressed that, and we actually had students on board who would have helped them, but we didn't actually have a resounding need for those services from the students.
Okay, thank you very much. We need to move on to our next talk. This was an excellent presentation. Susanna, you're going to introduce the next speaker.
Yes. I'm honored to introduce Dr. Ella Chapman Davis, who is an associate professor of obstetrics and gynecology, and the recently, sorry?
I thought Tracy was up next, Dr.
Oh,
Paul.
I'm sorry, I'm too far down.
Yeah.
Sorry, I will be honored to present Dr. Chapman Davis in a few minutes, but now I'm honored to present Dr. Tracy Paul. Sorry, I scrolled too far. Who is an assistant professor of clinical medicine in the Division of Cardiology, and a wonderful doctor and human being. And she's going to present her project on hypertension control in the age of COVID-19, utilizing telemedicine. Can you go back? For hypertension treatment lifestyle modification in Central Harlem.
Okay, thank you so much, Dr. Morales, for introducing me. So just wanted to give a little background. So as we all know, due to the coronavirus pandemic, there's been a total disruption of the way healthcare is being delivered in this country, especially when it comes to outpatient care, and especially when it comes to chronic disease management and treatment, when we think of diseases like hypertension. The COVID-19 pandemic has also illustrated that certain chronic diseases like hypertension, which are more prevalent in ethnic and racial minority communities in the US, that there actually may be some sort of link to increased mortality from COVID-19 infection. We've seen that the pandemic has really highlighted the lack of health equity in our society, and also very much so in our city. So in New York City, about 2 million New Yorkers carry a diagnosis of hypertension, and the prevalence of hypertension among Black New Yorkers is about 35%. When we look at from a neighborhood perspective, Central Harlem actually has one of the highest prevalence rates of hypertension throughout the city, with about 60% of residents reporting that they've been told that they should be taking a blood pressure lowering medication. Central Harlem is a predominantly Black neighborhood, with over 60% of residents identifying as non-Hispanic Black. It also is the second poorest community district in the borough of Manhattan, and has been identified by the federal government as a health resource poor area. So given what we know about COVID-19 pandemic, the prevalence of severe COVID-19 in persons living with hypertension, and already the poor health resourced areas that we have in our city, it's pretty prudent that we think of innovative ways how to address these disparities in the time of social distancing and lack of in-person patient-provider interactions. And so thinking of that, given the use of telemedicine and the expansion of the use of telemedicine, I thought about, what about delivering community-based hypertension interventions, so like lifestyle management, just teaching people about hypertension and how to control it through the use of telemedicine. So our project design is that we're going to use telemedicine to deliver hypertension lifestyle interventions in a primarily African-American population. And our setting is the Boys and Girls Club of Harlem. So this club, it's located on 145th Street, and it's been in the Harlem community for about 40 years. It's primarily targeted towards youth enrichment. However, the club recognizes that a lot of the parents of the children who are club members are really looking for adult-centered programming ran by the organization. And they also want a particular focus on health programming. So our primary objective is to test the feasibility of creating a health education telemedicine curriculum for community dwelling adults in an underserved, under-resourced community. Our secondary objectives are to see if we can help improve hypertension control through hypertension lifestyle education, to see if we can improve average weekly steps, so to encourage more physical activity, and to see if health attitudes and behaviors improve as determined by a survey that will be given at the beginning of the 12 weeks webinar and then at the end. So in terms of project design, so we're really looking for adults who carry a diagnosis of hypertension, so self-report, and looking to target about 40 to 50 adults who have a connection to the Boys and Girls Club. So we are going to have a focus group with the community organization members for curriculum input to make sure, that we touch upon different aspects of hypertension that community members have been wanting to talk to a doctor about. So the structure will be a 12-week program, and during those 12 weeks, we'll have 5 webinars, and these are the topics of the webinar. So hypertension education, nutrition, where we'll talk about the DASH diet, the Mediterranean diet, and we'll have a nutritionist come on to answer certain questions and to also teach recipes that are heart healthy. We'll have a physical activity component talking about exercise and really, telling people about the recommendations from the AHA ACC in terms of like how much exercise someone should be having done, and featuring a trainer who can show exercise that can be done in the home and talk about exercises that can also be done outside, which can keep within social distancing. And then of course, mindfulness, where we'll have a therapist coming to talk about like stress reduction techniques with the participants, and also talking about, like how stress and like how stress and poor sleep hygiene can have detrimental effects on one's blood pressure. And then finally, the last webinar will really be a Q&A with healthcare professionals, and really a time for participants to reflect on challenges that they face, and like some of the pluses that they noted with the program and some of the minuses. Also during the project, we'll ask participants to self-measure their blood pressure at home. Like we're going to give them an automatic blood pressure cuff, and then we're also going to give them a pedometer so that they can record the amount of steps that they're doing per week. In terms of our survey, it'll be administered in the beginning of the 12 weeks, and then at the end, and then just compare and contrast. We'll also be giving a survey at the end to see like what participants liked about the program and what they disliked, to help us to kind of fine tune like our format. And ultimately the goal is to have this sort of telemedicine project in place with the Boys and Girls Club of Harlem, and so that at later dates we can swap out and do another topic, so like perhaps like diabetes or COPD. And so progress so far. So we finally received IRB approval. That was the largest challenge, as my co-winners know that I've spoken about in prior forum. We finally received it like just a few weeks ago. We've created rough drafts of the webinars to show the community focus group when we have it. We've also identified and interviewed a nutritionist to join our project. We're ordering our blood pressure cuffs, pedometers, and tablets, and our focus group will be held in mid-March, and then enrollment to start in late March. So while we had like a bit of a later start than the other recipients, mainly because of IRB, I think we're on a pretty good track, because we pretty much have a lot of the elements that we need in place, and it's really about like inviting participants and getting the group off and running. And so, I want to say thank you to everyone who's been involved in terms of like concept of this project, application for the grant, and then of course to our residents and our medical students. We're also partnering with the Minority House Staff Council, with Fabian Vargas leading that group of residents, and then Yendi Grill, one of our third-year medical students, who's also leading the medical students. Because basically what we're anticipating is that the residents and the medical students will be in contact with study participants, like asking them, like, what was your blood pressure readings for the week? How many steps did you take? And just having like a contact with us here at the medical center.
Okay, we want to have a minute or two for questions. Are there some questions?
I don't have a question, Tracy, but I just want to point out that I sent you a chat. I don't want to take up time.
Okay.
What is your sense of the community receptivity to what you're doing?
So, so I've worked with Boys and Girls Club in the past, like through other avenues, and they're very receptive. They're already asking me if we can at least do an extra webinar about like COVID-19 vaccine. And the
Awesome.
Sorry. Wait, what?
My obsession.
Okay. So they're very excited, like I've done stuff with them in the past, like in person, but just like kind of like one-time talks or whatnot. But they're very excited about having a longitudinal program.
Okay, any further comments? Thank you very much. Go ahead, Susanna, introduce our next speaker.
Okay, now I can introduce the outstanding Dr. Chapman Davis. Sorry about my boo-boo. So Dr. Chapman Davis is an associate professor of obstetrics and gynecology and the recently appointed new division director of gynecologic oncology. So we're very honored that you're part of this group. She's also the Donna Riddell Clinical Scholar at Weill Cornell Medical College. And she's also, I just wanted to mention, recently operated on 2 of my patients who I just saw, who talked a lot about her compassion and just general wonderfulness. So I want to express a personal thanks for your care, your clinical care of our patients. But her talk today is entitled Patient and Provider Experiences with Telemedicine Utilization Among Underserved Women Seeking Gynecological Care in the era of COVID-19.
Well, first I'd like to thank everyone who's been a part of this project, and especially Susanna. I love taking care of our patients, and I think it's really important to have not just research, but also kind of provide the true clinical care and connection that I have with a lot of our patients. So first of all, I have no disclosure, but obviously I'm very excited to be a recipient of the COVID-19 award. Here's a list of my fellow co-investigators who also have been very involved, including Chinzam, who's been a wonderful medical student, and Ngozi, who was actually a previous Cornell medical student and now a PGY2 and OBGYN in our department. So what do we know about the use of telemedicine? I mean, evidence suggests that telehealth in general has the potential to provide comparable health outcomes without compromising the patient-physician relationship. Now, pre-pandemic, our society, the American College of OBGYN, thought that they had, but in order to have ensure good health services, you were supposed to have secure, stable internet connection, necessary hardware, and they talked about liability insurance and all these resources. But then obviously the COVID-19 pandemic hit, and what followed was just rapid initiation occurred of telehealth, but not accounting for all of these things, and specifically amongst underserved populations and rural populations. And there was no time to address any of these barriers. And also there really was no guidelines addressing best practices for telehealth in these populations. So there have been plenty of studies that have found that underserved populations were less likely to use live video communication or telehealth services as compared to other populations. There's been reported barriers, as previously discussed, including language barriers besides technology and knowledge. So in order to identify these barriers and create best practices, as we've talked about in previous presentations, there really needs to be a needs assessment. And a lot of these needs assessment really needs to be driven by the patient-provider experience. And so one of the things we found ourselves at our NYP Women's Health practice It's a clinic that serves underserved women, primarily providing care in obstetrics and gynecology, but it also includes subspecialty clinics including high-risk OB, infertility, gynonc, and urogyn. Unlike SEMA, specifically in the women's health practice, it is overseen just by residents, fellows, and nurse practitioners with the attending sort of overseeing these patients, but is strictly limited to just Medicaid patients. During the height of the COVID-19, our clinic volume decreased to maintain a goal of less than 30% of in-person capacity. Now, although that has changed over some time, the goal practice capacity for telemedicine we'd like to continue is about 40% of all clinical encounters. So our study objective were to evaluate the patient acceptability, feasibility, and satisfaction within general gynecology as well as subspecialty gynecologic care with telemedicine. And we wanted to look at this from both the patient and the provider perspective. Now we limited to just GYN because there has been a lot of data around obstetrical care with telehealth already, and there's been a lot of other ongoing studies. Some of our aims were also to identify barriers based on telemedicine utilization, and then also subsequently determine concordance between patient and provider experience and use this information to optimize care in our clinics. So we included any patients over 18 who were seeking GYN care and from subspecialty care. We excluded patients who needed interpreters for this initial part because we thought that's a whole nother area that needs to be addressed. And our provider population was, as discussed, were mainly trainees as well as nurse practitioners. So this was just a schema of our project, which we finally got IRB approval and started. Every person who was offered a telemedicine visit and accepted was called about a week prior and right up until their appointment to see if they would want to be a part of the study. If they accepted, then right after their televisit was over, they would be contacted and undergo a survey questionnaire via telephone about their experience. And if those patients did it, we also made sure the providers who were involved in that encounter also underwent a survey. And among some patients who were offered, they declined up front. So we wanted to sort of know what happened to those populations of patients. And so we contacted those patients as well and asked them if they'd be willing to do a different survey that we call the decline survey to see reasons why they declined the telemedicine visit. So this is just some preliminary data. Again, we've only been recruiting patients for about 6 weeks or so. And so this was just trying to give you a kind of a brief glimpse into our study population. So within our provider populations, we have about 34 providers who've been involved. The majority of them were residents. The majority of them were sort of mid-level, early stage residents. We also had nurse practitioners. And the fellow that was involved was our gynecologic oncology fellow. We only have one, so that's why you see that there. She pretty much does all the video visits for our patients. The majority of the patients for video visits were follow-up visits and were among benign GYN. As far as our patient population, we had about 45 patients so far enrolled. The majority of them are younger, usually less than age 65, which is not so unexpected, but something to think about. In terms of race and ethnicity, we had a pretty good broad range, with the majority of our patients being Hispanic or African American, as well as a range across white and Asian. The majority of our patients had at least a GED level, and 73% had children. And currently in this climate, we actually found about half of them were unemployed. So some of the preliminary themes that we received from our patient surveys is that 84% of patients reported that they thought it improved access to GYN services, with one question we asked: without telemedicine, I would have not been able to get the GYN care I needed. And 47% of patients agreed to that statement. 74% agreed that these visits over telemedicine was just as good as in-person visits, which I think was a good thing to hear. Two of the things that I thought were really telling is that one of the questions we asked is that if they thought telemedicine was good for a first-time visit versus a follow-up visit. And as you can see, 82% of patients thought it was good for a follow-up visit, but about only 30% of patients thought that this was a good method for a first-time visit, especially when they're seeing a specialist. When some other benefits from telemedicine that we wanted to look into, especially in our population, was to look that if you didn't use telemedicine session, what would that mean for them? And so some of the things I thought that was interesting to show is that almost, 45% of patients would have had to travel between 1 to 3 hours to be seen for an in-person visit, and 70%, almost 70% of them via public transport. And we also wanted to look at if the cost of traveling, just thinking about other expenses such as childcare, what would that mean for them financially? And I thought it was interesting that we found, a good population of patients that they would maybe have to pay upwards of $150 of missed work or expenses for them to just be able to show up to their visit. So I thought that this was also telling about that, how telemedicine really should be here to stay. Some themes from the provider surveys we found was that 100% of providers obviously assumed that they thought that they improved access to GYN care, and also 90% thought that they were able to adequately counsel their patients. But what I thought was relatively telling, though, although they said that in the statement that said, I believe I was adequately trained to provide telemedicine visits, only 61% agreed, with about 30% being neutral and 8% who disagreed. So one of the things is, as we think about being providers to patients in the world of telehealth, we really need to think about training our actual, trainees to do this type of visits, because I do think there is a little bit of a difference in terms of learning how to be a good doctor to provide telehealth visits. Some of the barriers reported by the providers related to drop calls, poor signals, poor connections, and language barriers, but only 2.9% actually said it was an EMR issue. So in general, some of the pitfalls, challenges we have had with this study was sort of retention of the consented patients. Patients did agree to do it, and then they wouldn't pick up the calls after they finished their visit. And I think one of the issues is that as most people look at their phone calls, no one picks up numbers they don't understand or they don't know. So we sort of had to make some changes with implementing a call, then a text, then a second call, and then more people would pick up on the second call after the text if they actually knew you were the person that had reached out to them about the study ahead of time. Other things, just thinking about completion of the provider surveys. This has been a big deal. So I said, if our patients can do it with their children and all these other things, our poor providers could not get these surveys done. So we had to implement a multi-pronged approach, which ultimately led to attending pressure besides text messages, emails, and even making it very simple with in-person label surveys. So our goal is to do around a 6-month prospective study with the goal of about 300 patients. I feel like we obviously would like to continue to see these trends and get a better idea for interval analysis to help to address best practices for our patient and providers in the clinic setting. So thank you for all your time and consideration. And, obviously I think that what I've learned is really good that we work together. We need to listen to our patients. And as providers, we also need to learn that training is important continuously throughout our lives. And as this becomes something that I think is here to stay, that we need to think about all the ways that we can make it better from both sides. Thank you.
Thank you. I think we're pretty much out of your 10-minute block. So we'll ask that people send you any questions through the chat. And we're going to move on to the next presentation. Susanna?
Yes, sorry, 1 second. I do have a question that I will send you in the chat, Ella. Wonderful, amazing that you've obtained this much data already. Honored to present Dr. Christopher Gonzalez, our HRSA Health Equity Fellow in the Division of General Medicine, and a wonderful and brilliant young man who's been incredibly productive and is a really important part of our division. So Chris will present on experiences with social distancing during the COVID-19 pandemic among Hispanics in New York City. And he has several amazing collaborators who I'm sure he'll talk about.
Yeah, so thank you, Dr. Morales, and thank you to everyone. And thank you also to all the extraordinary people that already presented. Dr. Chapman, it is an honor, an intimidating honor to follow you. But aside from that, I also just want to thank the amazing researchers that I've been able to do this project with, in particular, Dr. Shapiro and Dr. Sterling, both of whom I think are on the call. And today I am going to be presenting experiences with social distancing during the COVID-19 pandemic among Hispanics in New York City. So unfortunately, the COVID-19 pandemic has had a disproportionate impact on Hispanic adults nationwide, and that's not untrue of New York City as well. According to age-adjusted data from the CDC, the rates of cases, hospitalization, and deaths among Hispanic adults are higher than those of non-Hispanic adults. And while social distancing and quarantining are effective methods to reduce the spread of COVID-19, Hispanics, who are statistically more likely to be frontline non-remote workers and to live in multi-generational households, may face a number of unique challenges that limit their ability to really carry out those preventative measures. So we outlined two aims that would allow us to better understand this inequity. The first one being that informed by the health belief model to elicit the experiences of under-resourced Hispanics towards social distancing and quarantining during the COVID-19 pandemic in New York City using qualitative research methods. And the second aim was to train and mentor underrepresented minority students in qualitative research methods and principles of community engaged research. In regards to our study design, from June to November 2020, we recruited self-identifying Hispanic patients from a federally qualified community health center in East Harlem, also known as Spanish Harlem or El Barrio. And we collaborated with this clinic, which offers numerous resources for the surrounding predominantly Latino community, and is also where I practice clinically as a primary care doctor. So we conducted one-on-one interviews with 20 patients using a topic guide based on the health belief model. And interviews were done by phone. They were in Spanish or English, and they lasted approximately 30 minutes. And the interviews were recorded. They were then transcribed and independently coded by two coders who were trained and were student coders. And then those codes were reconciled by a third member of the research team. And codes were ultimately grouped into major themes and sub-themes by consensus. So I'm going to go ahead and present the results, just given the time, the results of our study. We found that there were 4 major themes that emerged, each with sub-themes. The first theme was just that there was a lot of fear of contracting and transmitting COVID-19. There was substantial knowledge and fears regarding the virus and the pandemic, with many participants, unfortunately, as we heard of a little earlier as well, having been exposed to the virus either directly or through close contacts. As one person noted, we began to see it in people close to us. My friend was admitted to the hospital, then another person passed away, then my son's coach also passed away. The second theme that emerged was that was engaging in practices to reduce transmission. So this frequency of risk, along with the fear of exposure, often contributed to a deep commitment to really taking standard precautions and gathering as much information as people could. But simultaneously, individuals were also taking extraordinary precautions. As one person said, I was without a home health aide for 2 weeks because I was afraid of getting infected. I had to do everything with one hand because my other hand doesn't have strength. I couldn't take a shower. And this is an individual who just wouldn't let their home health aide into their home out of fear of exposure. The third theme that emerged was barriers to social distancing and quarantining. So despite attempting to take precautions to minimize their risk, numerous challenges really limited their ability to do that adequately. This included financial and social obligations, including their roles as essential workers, as family caregivers, and as even just short-term caregivers for individuals to support loved ones who had recently become sick, which obviously put them at risk. As one person put it, when my husband got sick, we couldn't just leave him. He would stay on the bottom bunk bed and my son and I on top. That was the only distance for us. Additionally, participants often cited a lack of reliable and practically useful information. That's something that also came up. The fourth and final theme that emerged was the enduring psychological and physical toll of the pandemic, even for those who didn't contract the virus. Together, the increased risk of fear and exposure, coupled with those multiple barriers to social distancing, really strained the psychological, physical, and financial well-being of the community at large. As one participant put it, it wouldn't let me sleep. I was too afraid to. The last time the ambulance came, he told me it was a panic attack. And this really goes to show the kind of interaction of physical and psychological symptoms and their overall self-perpetuating impact. Despite all of this, though, I should know that there was a tremendous amount of hope and resiliency in the community overall. So summarizing our findings and their implications, our study elucidated some of the unique barriers of social distancing and quarantining faced by under-resourced Hispanics in this community. It also elucidated the need for tailored messages from trusted messengers and the need to measure and address the collateral impact of the pandemic at large, as well as the need to really address the underlying social determinants of health. Finally, I did not want to go without saying and talking about AIM 2, which was, I was going to say it was my favorite part, but honestly, this entire experience has been incredible. Our second aim was really to train students who were traditionally underrepresented in medicine in health equity research in practice. And along the course of the project, 4 students have gained a variety of skills pertinent to its development. And we've had the opportunity to develop and execute a curriculum in health equity research in practice. And the topics that we've been talking about are covered here. So just given the time constraints, I'm going to end there, but I am obviously very excited to take any questions.
We have a couple of minutes for questions.
I have a question. The interviewer, some of that content from the patients that were interviewed was incredibly moving and heartbreaking. How did the students, I think, were the main interviewers, is that right?
No, so I actually interviewed the participants, but the students went through multiple
coded it.
The transcripts.
I was actually just interested on this whole phenomenon of bystander trauma. I mean, I think we're all experiencing this. Any of us that do clinical medicine, we're dealing with survivors and people in fear, but it's just very profound what you uncovered.
So absolutely, I can tell you just personally, it was, we're seeing it in clinic and then hearing it in 30-minute interviews of talking about all these issues that are really challenging to address. It was hard, not to mention a lot of my family members are in those circumstances as well. With the students, I think it was the same thing. We tried to stop as frequently as possible to just touch base with everyone and talk about some of the things that were going on, not only processing it from a research kind of qualitative coding standpoint, but also processing personally going through these narratives. And I think for everyone involved, it was a learning experience.
Other questions?
It certainly is. Oh, go ahead.
Yeah, I mean, I just thinking about it, and actually with all the vaccine education that we're doing, part of what I've been feeling, one of the things that you identified is lack of information for people, that there hasn't, except for things like on TV and the radio and misinformation frequently on social media, there hasn't really been a great effort throughout the pandemic about COVID information. And I'm finding that people still have a lot of poor information, and they're still asking about basic stuff about quarantining and things like that.
So going back to your question, actually, and tying that into this idea of trauma, we presented these findings to our community partner, and a lot of the staff, this really resonated with them because they're part of the community, and yet they're also burdened with treating the community. So they're going through the same issues and yet trying to help other people go through that. And for them, they felt that they didn't have the information, even now that they can do something through the vaccine and the distribution of the vaccine. They didn't necessarily feel that they had the information or the experience to do that. So out of this research, we ended up organizing a number of talks, not only for the community, but also for the staff members at the clinic to kind of just know themselves, and also to be able to talk to their family members and to patients.
We're going to have to end. I would just note to Chris's project, I did help a little bit, but Maddie Sterling helped a great deal.
Absolutely.
It was absolutely crucial. These were 5 outstanding presentations, and it's really good work that's being done. Thank you, everybody, for your presentations and for the wonderful things you're doing to try to improve our care in this time.
Thanks, everyone. You guys are amazing. We really appreciate all your wonderful work. And thanks for everybody for attending. Bye. Have a wonderful weekend.
Take care, everybody.